Thank you, Annie. Delighted to be here. Welcome, everyone. So, welcome. Hello. Welcome to this evening's Croi webinar, Fingers on the Pulse for Stroke Awareness. My name is Dr. Lisa Hines. I'm a health psychologist and the head of health programs with Croi. I'm delighted to be hosting this evening's session. Over 400 people at this stage have now registered for the event tonight. It's really such an important topic and a broad topic that we're discussing this evening. You may know or not know that 1 in 4 people are at risk of stroke in their lifetime, but that there are some steps that we can take to help to prevent a stroke. Approximately 7,500 people in Ireland have a stroke each year, and it's estimated that 30,000 people in Ireland are living with some form of disability as a result of a stroke. But 90% of strokes are associated with about 10 important factors known as risk factors. And some of these risk factors are things that we can do something about in our lives. For example, high blood pressure, not getting enough exercise, smoking, high alcohol intake, high cholesterol. These are all really important things to tackle to reduce our risk of stroke, as well as to reduce the chances of having a second stroke for people who have already experienced a stroke. A really important risk factor for stroke that we're going to shine a light on this evening is atrial fibrillation, and that's a condition that causes an irregular heart rate. So we'll get into all of those topics in a lot more depth as we go through the session this evening. And to go through all of those topics, I'd like to welcome our panel for this evening. So we have Professor Rónán Collins, the National Clinical Lead for Stroke and a consultant in geriatric and stroke medicine at Tallaght University Hospital. We have Prof. Jim Crowley, a consultant cardiologist in University Hospital Galway and the research and medical director here in Croí. We also have Trish Galvin, the advanced nurse practitioner in stroke in University Hospital Galway. And then we have 2 members of the public, and we're so grateful to these 2 people for being here this evening. We have Declan Fahy, who himself experienced a stroke in the not too distant past. Welcome, Declan. We also have Ed Cherry, who lived with and has recently now received treatment for atrial fibrillation. So thank you all again for joining us this evening, to the panel, as well as the people really across Ireland who have logged in this evening. I'd also like to thank our supporters for the webinar this evening, Johnson & Johnson, and they have a website, getsmartaboutafib.ie, that you can visit if you would like more information on AFib. As Annie said, we have a lot of questions to get through, and please keep sending them in, because we have the team in the background answering them live as well. So I'm going to do my best to bring all of those questions to the panel. Use the Q&A box on the bottom of your screen, as Annie described, or the chat box if you prefer. So we're going to jump straight into some questions, and we're going to start on the area of stroke. So to start with, Prof. Collins, can you tell us a little bit about what a stroke is and what causes a stroke? You're just on mute there. Sorry, Prof. Thank you.
I'm forgetting your excellent introduction instructions, Lisa. So good evening, everyone, and it's a pleasure to be here with you, with my colleagues, to discuss stroke on the eve of World Stroke Day. I'll start by prefacing my remarks, and I make no excuses for being absolutely biased in my opinions about this, but stroke is a major threat to Western society in particular. It is becoming our 2nd largest cause of death in developed countries, and it is also a leading cause of acquired adult neurological disability. Now, because of the success of aging and because of our demography, we are potentially going to experience a 58% increase in the absolute numbers of stroke in this country if we don't try and change the trajectory. So many of the aspects of what will be discussed here later tonight, particularly I might add atrial fibrillation and hypertension. It's very important that we get public engagement on this to understand that this prediction does not have to be a reality. I suppose in simple terms, and I was going to show diagrams maybe, but totally not to use slides. In simple terms, and I'm a great believer in trying to be very simplistic about stroke, because stroke medicine, most of it is very, very straightforward. Your heart has a pump which pumps blood down pipes. And the pipes, or the arteries in your brain, can cause a stroke by one of two mechanisms. Either something blocks the artery, or the artery ruptures and it bleeds. And in essence, that is what a stroke is. It's a certain interruption of blood supply to the brain, or a certain bleed into the brain tissue. And that will invariably result in either motor weakness, visual loss, or loss of kind of speech and ability to think and problem solve clearly if the stroke is large enough. It can involve a combination of all three of those things, or maybe just one or two of those things, or maybe even something even more minor. But in essence, all stroke is dangerous, but all stroke is also preventable to a large degree. And I'm very keen that we hammer home that message. I'll end my opening remarks by saying this, because again, public support can really help. I'm what's called the clinical lead or national clinical lead for the stroke program. That basically is the chairperson of a large group of people that have come up with a stroke strategy for the country. And we've submitted this stroke strategy to the HSE today, actually, on the eve of World Stroke Day. And it's an ask of 24 million over the next 5 years for an investment in 4 key areas of stroke: prevention, acute care and cure, because we can cure some strokes now if we get them soon enough. Restoration to living, because it's very important that we focus on getting people back to as full a life as possible if they've suffered a stroke. And in research and education, because research and education, and I include public education in that, drives change and drives progress.
Thank you, Prof. Collins, and so fantastic to hear that that went in today. That ask on those vital areas went in today on the eve of World Stroke Day, and a fantastic achievement. So you mentioned there how important it is for people to get treatment quickly. Can you give us a kind of a quick idea of how someone might know that they are having a stroke, or how they might know that someone around them is having a stroke?
Well, unlike a heart attack, unfortunately, a stroke can cause many different types of symptoms. And I suppose most people are very familiar with chest pain or sudden breathlessness as being potential symptoms of a heart attack. But of course, a stroke can produce a myriad of symptoms depending on which part of the brain is involved. We have tried very hard to focus on the real large type of pattern of strokes that we're really worried about. And rather than trying to give an array of every symptom that a stroke might cause, we have focused on very much the FAST message, which is face, sudden facial weakness, a drooping of the face down on one side, arm weakness, an inability to keep your arm up against gravity, a sudden disturbance in speech, which is the S, either your speech becoming suddenly slurred, or a person being unable to find the word suddenly that they wanted to say, or confusion around understanding language. So any sudden facial weakness, which is F, arm weakness for A, speech disturbance, which is S, then it's time to act quickly and ring 999. Nobody's going to criticize you if it's not a stroke. But don't be sitting there thinking, oh, I just slept on my arm, it'll go away. Or no, I just had a funny spell where I couldn't find my words. It'll be all right in a minute. Because these are real opportunity times for us to prevent something from happening. And even if the symptom has disappeared, come to hospital. Because very often, a bit like a volcanic eruption or an earthquake, you'll get a tremor before the major event. And again, that tremor is a very important warning sign and gives us an opportunity to prevent something larger from happening. So the FAST message is a very important message. Face, arm, speech, time to act, ring 999.
Yeah, and take action. Don't worry about being wrong. Yeah, great reminder. Thank you. And Trish, can I ask you to come in here and to tell us a little bit about the impact of a stroke on the person themselves?
It can have a huge impact, and it can have a very varying impact. And I suppose one thing that's important to say is the reaction that a person has doesn't always match with the severity of stroke. So people can have a mini stroke, a minor stroke, or go on to have a full, quite disabling stroke. But people's reaction to that can vary. People often feel fragmented after a stroke. They feel like they've lost a piece of themselves. Suppose think of a jigsaw. You know, you've opened up a jigsaw and you're trying to put it together. You get to the end and there's one or two pieces missing. And our job in stroke medicine, first of all, as Prof. Collins just said there, is hopefully to find all those jigsaw pieces and get the person back together before they're left with a disability. But it's trying to help that person to accept themselves after the stroke. And what's very important about stroke is that even though it happens to the individual, it has very much a rippling effect on the families. So the stroke survivor, but also their families, it can have a big impact. Often when I go to meet people in my job, I avoid telling them what my job title is until I'm about 5 or 10 minutes into the conversation, because I get a sense of when they're able to hear the word stroke. Because the minute they hear that word, their face changes, they gloss over, they don't hear a word that I say for the next 15, 20 minutes. It's something that just rocks them to the core. It's a frightening word. And people, for younger people that have strokes, because there is a lot of belief out there that stroke is something that just happens to old people. Well, it doesn't. It can happen at any age. It can be more common in older people, but it can happen at any age. And when it happens in a younger person, they can find it hard to deal with. And Declan, I'm sure later on will explain that to us. So we try and help people. We try and reassure them and offer them the best support we can to get their life back together again.
Thank you, Trish, and a perfect kind of introduction for Declan. I wonder, Declan, would you mind, as someone who has experienced a stroke, can you tell us a little bit about your experience, please?
Yeah, well, thanks for having me. First of all, and as Professor Collins was talking, unfortunately, I didn't really stick to the fast element of it. So it happened when I was 47, January 2020. I was at a committee meeting, and the first thing, I was holding the handle up the door. The first thing I noticed was that my arm had disappeared. At the time, sorry about this. At the time, I put it down to just being cold. It was a cold night, and I thought, like pins and needles, stuff like that, the feeling would come back. The next thing I noticed was the speech became a little bit funny. So I had been standing holding the door for quite some time, wondering where's my arm gone. It's completely missing. So I was shaking my arm to see could I get the feeling back. I went outside, talking to people that I was with at a meeting. I was at a committee meeting, and my phone dropped out of my hand. So some power had come back. So at that stage, then my brain started thinking, okay, well, what's going on here? You know, so I had suspicion of a stroke. My thought process at that time was to get home, to get back to my wife as soon as possible, just get home. And then when I got into my car, I started to wonder, was my mouth drooping? Was there a drooping effect from the rear view mirror? So quickly started to think that it might be a stroke. Probably unbelievable, but I drove home. Yeah, I can see Professor Collins' face. I got home, and it's when I got home then that I realized, as I came in the back door, I said to my wife, I said, I think I'm having a doke. My speech has started to disappear. Luckily enough, there was a paramedic that lives across the road from me, and he was contacted. He came over straight away. after that, everything happened very, very quickly. So like I have full recollection of it, in the sense that there was no pain, there was no warning. It was very sudden, unexpected. I bought new trainers actually on the way home for the gym at the weekend. So 47, relatively healthy, don't really drink, never smoked, quite active. So definitely didn't expect it. And then things just happened really quickly. Like I can remember the paramedic asking me to do things, and I knew what I need to do, but my body wouldn't respond. And then hospital journey.
Wow. Thank you for sharing that, Declan. And Trish, when you hear Declan's story, and I know you know Declan, you must see so many different experiences from people just reflecting different types of strokes or different backgrounds.
I suppose one thing that I say to a lot of people is don't compare yourself to the person in the bed next to you, because there's no two strokes are exactly the same. You may have the same features, you may both have a weakness in your arm, but it's not always the same. And how people rehabilitate and their journey after the acute event can be very different as well. Stroke varies from person to person, and also their level of fitness. And that's one thing that I think Declan had going for him, is he was a very fit and active man prior to his stroke. So that helped him through his rehabilitation. Having a strong mind and a strong willpower to help you through. And we're very good, we try to be very good, not always at the rehabilitating the physical side of stroke. The emotional and the psychological side is sometimes we probably fall down a little bit on. But yeah, stroke is very varying. If you do have a stroke, it's very frightening, but we're there to help you through the journey and to try to make as the best of recovery as possible.
I think the TV adverts as well. That
with the fast.
It does, like when it was happening, it did come into my mind. And as well as that, just the understanding of what Professor Collins was talking about, how important that is. Like if it was to happen again, I wouldn't be driving home. It's definitely stick to that FAST thing,
Yeah, thank you, Declan. And so a little bit of a kind of a left turn here for a minute, if you don't mind. We will come back around to stroke again, but we're going to change direction a little bit here to bring up that other focus for today that I mentioned, and then we'll come back to talk about the connection between the two. So, Prof. Crowley, could you tell us a little bit about atrial fibrillation, or AFib, like what it is and how it develops?
Thanks, Lisa, and thanks for inviting me to come to this. I think it's a great forum for, disseminating a lot of information on these topics. Atrial fibrillation is a relatively common heart rhythm problem, and in many respects, and for many patients, it's actually a bit of a nuisance, or in many cases, they're not even aware that they have it. But it is significantly associated with developing a stroke, and the type of stroke that's associated with atrial fibrillation is often of the more severe form that patients experience. Atrial fibrillation really refers to a rhythm problem where the heart normally beats at about 70 or 80 beats per minute, and this beating is very tightly regulated by a signal that passes from the upper chambers of the heart through the upper chambers, causing them to contract, and then down into the lower chambers, causing them to contract. And this is all very well controlled. But in patients with atrial fibrillation, the muscle fibers in the upper chambers of the heart, instead of contracting all together in a harmony, actually beat independently of each other. And if you were to look at the heart when a patient is having atrial fibrillation, it would look like that the upper chambers, instead of contracting and squeezing appropriately, just look like they are shimmering, like we call it a bag of worms. So the atria don't actually contract at all. And what that leads to is that parts of the heart, the upper chambers, blood can stagnate in parts of these upper chambers. And when blood stagnates, it can clot. And if you develop a clot in the upper chambers of the heart, some of that can break off. And if it breaks off, it can travel through the heart up into the arteries of the brain and block off one of the arteries, causing a stroke. And that's why we're so concerned about this condition. It's very common, and it gets common as you get older. And it is relatively easy. Well, in some cases, it's easy to identify. And in some patients, we recognize that certain groups of patients are at particular, with atrial fibrillation, are at particular risk of getting a stroke, and they sometimes require treatment such as blood thinners and so on.
Okay. And so can you tell us a little bit more about what someone with AFib might experience, and then how AFib is kind of diagnosed and identified?
Yeah, I suppose the big thing about AFib is there are two problems, if you like. You can divide the problems associated with AFib into two big groups. One is, if you like, what I would like to determine as called nuisance symptoms. Now, what I mean by that is these are symptoms that interfere with the patient's quality of life, and they can be very debilitating. In some people, they're actually very trivial. In some people, they have atrial fibrillation and it's just picked up at a screen for an insurance policy or something like that, and they have absolutely no symptoms whatsoever. But there are patients who experience atrial fibrillation when it comes, and they feel really unwell. They may have palpitations, they may feel a bit short of breath, they feel under the weather. They don't even know why they feel a bit unwell. And this can be very, very debilitating. That is, you know, a reason to get treatment for it. But the other big reason, of course, is stroke. And patients can present with stroke who never knew that they had atrial fibrillation. And so this is why we try to identify patients who have atrial fibrillation, and then we can, if you like, stratify their risk of getting a stroke and decide on what sort of therapy that might help them.
And in terms of diagnosis of AFib, there are a few questions that have come in around it. Is that okay if I put a couple of questions?
Sure, yeah.
So there's one question on wearables. Someone heard about a wearable heart monitor vest to replace a Holter monitor. Are you familiar with people using different kinds of wearable devices for this area?
I suppose the thing about atrial fibrillation, of course, is that it can come and go. So if you have atrial fibrillation, it may last for hours or minutes at a time and may go away. And so it may often be very, there are other patients who have it all the time, and it may be asymptomatic. So you may be getting this, it may be coming and going, and you may not be aware of it. And so when we try to diagnose it, it actually can be quite difficult to make the diagnosis. And so we have lots of different types of monitors that we can use, which help us to make the diagnosis. And you know, you have many of these smartwatches now are actually able to pick up atrial fibrillation. And in the end of the day, I think this is going to be the way that we're going to pick up atrial fibrillation in the vast majority of patients who don't have symptoms but who may be at risk of atrial fibrillation. The vest, I think, I'm not particularly familiar with that particular vest device, but there are monitors. Traditionally, what we used to use was what's called a Holter monitor, which was a monitor with 3 leads. 3 wires were attached to the chest by stickers and then attached to a box which you could wear. And this would record the heart rhythm over 24 and 48 hours. We still use that quite a lot. The problem, of course, is that if you have it on for 24 or 48 hours, you may be absolutely symptom-free and yet still be at risk of developing atrial fibrillation. So we use other monitors now, or the devices that we can inject under the skin, which may record heart rhythms for up to 3 years. Or we have other devices, as I said, wearables, which I think are probably the easiest way to go about making this diagnosis. And these watches or these apps that can be downloaded onto your phone, so that if you do feel something, you may be able to record what the rhythm is like. I think this is probably the way forward in many cases.
So they're generally pretty, they're good enough measures to at least identify if there might be a problem.
Yeah, in many cases they are good enough. Sometimes they, if you like, overdiagnose. So it is important that tracings be obtained so that they can be analyzed by a specialist or a doctor, so that they can see whether this is truly atrial fibrillation or simply not due to, say, a muscle artifact, which is the most common thing. It appears that if somebody's running or if the contact with the skin isn't quite accurate, then tremors or muscle tremors may be mistakenly interpreted by the device as atrial fibrillation. But they are very useful, and their sensitivity is getting better all the time. So I think certainly in high-risk groups of patients, they are probably the way forward for helping to pick up patients who have atrial fibrillation without symptoms.
Okay, really interesting. Thank you. So one more question. So the question comes from someone who was 55, diagnosed with AFib last year, but was told that it didn't run, in inverted commas, for long enough to warrant medication. The person also has issues with high blood pressure, but it's under control, but they're worried about the AFib because they know it's a risk factor for stroke. Do you have any thoughts on this person's situation?
Yeah, this is a particularly difficult problem because this patient has hypertension, which is considered to be a risk factor for stroke, independent of atrial fibrillation. But also, if you have hypertension and you have atrial fibrillation, that increases your risk significantly of getting a stroke. The one issue here is how long did the patient have atrial fibrillation? And there's a lot of controversy, or it's not controversy, I suppose, it's need for further research onto what is the minimum period of atrial fibrillation that's associated with the risk of stroke. But it's probable that most patients who have atrial fibrillation, even if it's documented for a short period of time, that they probably have it actually for significant periods that we're not detecting at all. So we tend to err on the side of being safe, and that is if a patient has short periods of atrial fibrillation, then they would be considered to have atrial fibrillation, and therefore they would have a risk of stroke. But then on top of that, we have to try and graduate that risk of stroke if that's possible, because we have blood thinners, which are agents that you can take if you're at significant risk of stroke, and these substantially reduce the risk of having a stroke. However, you know, if you have atrial fibrillation and your risk of stroke overall is only slightly increased compared to the general population, adding in a blood thinner agent may not actually significantly reduce your risk of stroke at all. And the blood thinners themselves are associated with a small risk of bleeding. So one has to balance it up, if you like. And so a patient who has hypertension at the age of 55, who has been defined as having stroke, probably is one of those on the cusp patients for needing anticoagulation. If they had hypertension and had another risk factor such as diabetes, then there would be no question those patients would probably be recommended to have to go on a blood thinner. We can look at the patient with hypertension at that age, and then do other tests such as echocardiography and see if there are other, if you like, softer signs that might point us towards putting that patient on anticoagulation or not, you know. But certainly for a patient like him, it's probably borderline, and if there was no other risk factors associated, I probably would not put him on anticoagulation at this time. But I'd be interested to see what Rónán has to say about that one. It's a kind of, it's about, you know, there are many questions now, I think, that you know, if you look at the evolution of the management of patients with stroke and atrial fibrillation over the last 15 years, the evolution has been phenomenal. Not only we have now identified good drugs that we can use, which have a relatively clean profile that can be used to prevent stroke. These are the newer anticoagulants. And we also have good treatments, drug treatments and invasive procedures, which can help with the symptomatic relief of atrial fibrillation over the past 20 years. So we have a large cohort of patients with atrial fibrillation that we know should go on blood thinners. And we have I suspect a smaller, well, it's probably a relatively large cohort of patients as well, who we know probably do not need anticoagulation, at least until they get a bit older. And then we have the gray zone, and this man is probably on the gray zone, but in a few years he will definitely qualify for anticoagulation.
Thank you. That's so interesting. And as you said, it's complex and there's a lot going on. And I will come back to some of those points shortly, if that's okay. But I kind of wanted to take this opportunity now while we're talking about AFib to invite yourself, Ed, if you don't mind, to tell us a little bit about your experience of living with AFib, maybe the symptoms that you experienced and when that came about, just your story on that.
Lisa. Yeah, I'm obviously the bag of worms that Jim was talking about earlier on. So I've been a relatively fit and healthy person all my life. I didn't go to hospital for treatment at any stage, and was actually on a hockey tour, vets hockey tour. It was a hot country. We were in Barcelona. It was 36 degrees. We were enjoying ourselves. We'd had several glasses of wine. We'd eaten well. And we were playing sport probably for the first time in about 20 years. So those factors were not helpful to my heart. And about 15 minutes into the last game, I just was feeling rotten. And I had to take a knee. And if I didn't take the knee, I was probably going to fall over. And needless to say, I was subbed off and not watched particularly carefully. My heart rate resolved and I was fine, and that was grand. But I had a history, so I've had some training in cardiac, and I knew what had happened. And a bit like Declan, I didn't do well, he did a lot more than I did. I did nothing for months, and I would actually do the reverse of what you're supposed to do. I stopped exercising. I started hiding. I was putting on weight. I was working harder. All the things just that was contrary to what I should have probably been doing. And I would find that the heart rate would increase if I was doing something moderate exercise. Certainly hills were a thing that used to get me. And if I was walking up a hill with the family, then my heart rate would take off. I could turn around and head back to the car and it'd be no problem at all. It'd settle. So I was pretty sure I had atrial fibrillation and I didn't do anything about it. It got to the point where I'd be sitting watching telly at 9 o'clock at night after having dinner, and a glass of wine with my dinner, and my heart would take off while I was sitting watching telly. No stress, relaxed, easy. But I've subsequently discovered that a glass of wine is often enough to trigger an arrhythmia, and it was certainly not helpful in my case. So eventually, in the middle of COVID, my wife had had enough of me complaining about it, and I was off to the GP, diagnosed with high blood pressure, cholesterol. I also had reflux acid, and I had arrhythmias. So I was into the hospital.
Thank you, Ed, and we will come back to your journey as we're going through, if that's okay. So I want to now. I'm going to keep pulling the strands together there, if that's okay. We're covering so many fantastic topics. So, Prof. Collins, can I invite you in here? So, we've talked now about AFib and how it's about heart rate and the bag of worms in the heart, and how it can cause the coagulation of blood, which can travel up to the heart. And we've talked about stroke, which happens in the brain. So can you just again kind of really emphasize the connection there between the two for us before we move on to the next part?
Well, the first thing, I'm watching some of the questions coming through, and I see Bridget Cheesty has been very busy there typing back to people. But let me just do a rapid fire, just through quick ones that I can maybe help people with. One question was that, is a stroke caused by a bleed more dangerous than a clot? The short answer is that a bleed is more likely to be fatal, but not all bleeds are the same. So again, not all two strokes are the same. It's difficult to generalize, but But as a concept, bleeding in the brain is more likely to be serious in the short term. But the long-term result from a stroke is very individualized and it can change. The second one, someone is asking, said her sister had an injection for a stroke in the US and has no longer any symptoms. So that's probably a reference. There's two acute stroke treatments available in Ireland. One is thrombolysis. So if you think of a blocked pipe in your brain, thrombolysis is like pouring domestos down the pipe to open up the blockage, and that will work for particularly smaller clots, and it's useful if given within 4.5 hours after the onset of the stroke. The other acute treatment we have is like a dino rod, where we go after much bigger blockage by putting a catheter up into the artery. At the moment, that's a pretty specialized and a relatively new treatment. We're providing that at 2 centres in Ireland on a 24/7 basis in Beaumont and in Cork. We will have to look at the future. The service is available, of course, to people in the west of Ireland. We're doing rapid transfers to Beaumont, and we are looking at the population demography going forward as to how we will put a 3rd centre going down the line. But it's a highly specialized technique. And I would also like to say to people, because everyone slams our health service, we provided thrombectomy to 9% of stroke patients across the country last year. The UK managed 1.4%. So to put things in context, not everything is rubbish in Ireland. There are some fantastic advancements going on as well. I think we should say that to say, someone has also asked a very good question. Are we going to move fast to faster? Faster is an anagram that stands for face, arm stability, T for talk, E for eyes, R for react in time. It throws in the important symptoms of sudden loss of balance and sudden eye symptoms such as loss of vision and double vision. There's another version of that called BFAST, which is balance, eyes, face, arm, speech time. The problem with introducing new acronyms is that we still have a very poor penetrance of even the FAST message, as Declan will have alluded to from his own personal experience. And we're really keen that we get the FAST message home and embedded amongst the public. We need to have that advert back up and running. Our own research nationally has shown that once the advert disappeared, all the progress we made in people recognizing the symptoms of stroke was lost, particularly in working class areas, I have to say. And so it's very important that we get that public education. And we've actually sought within our stroke strategy to have a protected budget for stroke and for allied conditions such as hypertension and atrial fibrillation, that we can run serial public education, because it's very important that the public understand what we're talking about. Jim refers to the bag of worms. My own personal analogy for atrial fibrillation, Jim will have heard me use this, where Jim and myself talk a lot about atrial fibrillation, is the cement mixer or the food mixer, because your heart is a pump, and above the pump, if you think about it, you've got a mixer feeding the blood into the pump. And if you think of a faulty cement mixer or a faulty food mixer, what will happen is you will get the mixture coating along the walls of the mixer. And the problem is that if some falls off the wall of the mixer, it'll fall down into the pump, and then we're in trouble. It's like a bullet falling into the chamber of a gun, and it's going to be fired down the pipework, and it's going to cause a blockage somewhere. So going back to some of the questions, and Jim asked me the difficult question about younger people with atrial fibrillation, and I think he answered on behalf of both of us. The short answer is that with regard to atrial fibrillation, there are things we know, things we know we don't know, and things we don't know. And we're still evolving our understanding of atrial fibrillation. Jim will probably agree with me. We're now beginning to increasingly recognize we may even be able to identify people who have pre-atrial fibrillation before they even develop atrial fibrillation. And so understanding how dangerous an individual person's mixer can be very difficult. Sometimes we need to directly visualize it. Sometimes, as Jim was saying, having the presence of hypertension or diabetes automatically suggests to us that that mixer is risky in a patient. And of course, now we have blood tests as well that are increasing saying that, okay, this mixture might seem relatively safe on the overall profile, but some blood tests can show markers that suggest that maybe the heart is under more stress than we realize. So it's a moving feast here, and Jim and myself, we're both involved in part of a wider interdisciplinary group to kind of look at stroke prevention and atrial fibrillation in Ireland. The pandemic held us up with what we planned to do, but we're going to start with a gusto again in the start of the new year, because one of the things that both Jim and myself are very keenly interested in is not just in preventing stroke and atrial fibrillation, but can we prevent atrial fibrillation in the first place? And can we cure atrial fibrillation in people who've just started to have it? And this is very important because atrial fibrillation is an age-related condition. And if we don't tackle this, they're reckoning we could have 20 million people in Europe living with atrial fibrillation in 20 years' time. That is a massive threat, not just to the risk of stroke, but to the quality of life of people. Because as Ed alluded to, although many people have no symptoms, a lot of people feel fatigue or lose their vigor when they have atrial fibrillation. And so we want to try and prevent people from getting atrial fibrillation. We want to try and get the people who have it early, see can we cure it. Jim is the expert in how we can cure atrial fibrillation. And of course, all that will lead into better quality of life and better reduction in stroke prevention going forward. So I think overall, both blood pressure and hypertension are also very strongly related. Most people develop atrial fibrillation from blood pressure. There are other risk factors, including putting on weight and being relatively sedentary, but blood pressure is a major driver of a lot of risk. And as I'm talking to a cardiovascular community, I might just finish on this point. If you asked me as Minister for Health, what would I invest in? I would invest in detecting blood pressure when you're in your 40s. Because if you get blood pressure right in the population in your 40s, you will prevent a lot of heart disease. You'll prevent a lot of atrial fibrillation. You'll prevent a lot of dementia. You'll prevent a lot of blindness. You'll prevent a lot of heart failure. You'll prevent a lot of kidney disease. Blood pressure is the greatest threat to successful aging. There is no doubt about that in my mind.
Thank you.
Yeah, I'd have to agree with all of that, Rónán, I think. And it comes back to, we end up talking about the same thing all the time. I mean, in medicine and in heart disease, we talk about risk factors. It keeps coming back to the risk factors, and hypertension is the big one, particularly for stroke and also for atrial fibrillation and for heart failure. And we know our own colleagues, Ken MacDonald in Dublin, did a lot of research on this and has identified significant reductions in the incidence of atrial fibrillation if we manage the risk factors in the early population. So if we can identify the major risk factors, we're on to a winner, I think.
And so when we talk about identifying risk factors and people understanding their risk and taking action on their risk, can we get into that a little bit? So, Trish, would you kind of help us to come back a little bit and get into this whole idea of risk factors?
Suppose, what is a risk factor? So, put it simply, a risk factor is something that increases your chance of developing a disease. And if we look at stroke or cardiovascular risk factors, they share a lot of the same. And when we look at risk factors, we sort of divide them into things you can do something about and things that you can't. So the things that you can't do something about is age, getting older, to a certain degree now, your gender. So in younger males under the age of 55, it's more common. Stroke is more common in younger males. But as women get older, it becomes more common in older women. So over the age of 70, it becomes more common then. Then there are certain genetic factors that people are born with and that can put them at a risk of stroke. Now, I'm not going to talk about them because they're very, they're another topic, but there can be some inherited diseases that can put you at a higher risk factor from stroke. You can have problems with your blood coagulation, your thickening of your blood. So they're the ones that we sort of can't do anything about, but it's the ones that we can, what we call the modifiable risk factors. And not to go too much into it, I'll quickly touch on what they are. So we talk about the medical problems, and then we talk about lifestyle. But it's important not to separate those two out from each other, because if you have been diagnosed with high blood pressure and you're taking your blood pressure tablets, but you continue to smoke, you continue to drink above the recommended allowance of alcohol, you don't exercise, you know, you're nearly undoing the good of what you think you are with that your tablet is doing. So you have to take control of your risk factors, educate yourself. So we've already spoken about 2, high blood pressure. Do people know what is high blood pressure? Do they know the magic numbers? So roughly, and they've come down since I started working in nursing. When I started working, people that had a blood pressure of 170 was considered high. Then it came down to 160. Then it came down to 150. We're at 140. So, you know, the more research and the more that we get to know about blood pressure, those numbers are coming down. So having a blood pressure consistently over 140 on 90 can be considered pre-hypertension, or you might be looking into that phase of certainly needing to control your risk factors and becoming aware of the problem. Atrial fibrillation, which we're talking about today. Having a high cholesterol. So again, it's very important to know your cholesterol, because what that can do is it can harden the blood vessels, but it can also block those pipes that Rónán was talking about earlier. So it can build in and narrow the pipe. So think of an old iron pipe, you know, and it corrodes and it narrows the center of the pipe. So cholesterol, and if that narrows the vessels bringing the blood up to your neck, that can cause a stroke. Diabetes and is another significant risk factor for stroke. So they're the major risk factors from the medical perspective. And then the lifestyle, okay, drinking to excess. So if we all know our units, so those that live in the border areas of the country, I don't know what way you like to look at it. So the Irish guidelines are 17 units a week for men and 11 for women. But if you live in the UK or the north of Ireland, that's 14 across the board. So if you live in the border and you hop over to Northern Ireland, for your woman, you can have 3 more units, but the lads, you have to drop down the 3. But be sensible about it. It doesn't mean you have to have those 14 or 17 units a week. And if you do have a drink, try and leave at least 1 or 2 days or nights a week where you don't have any alcohol intake. Smoking, a huge risk factor. So try and cut down. And as Rónán said earlier, we all start aging from our 40s, you know, and even though you may have a stroke when you're 70 and 80, it's what we're doing to our bodies from our 40s that will, you know, determine how we age and age healthily, because that's what we need to do. We need to learn how to age healthily. Stress is a huge risk factor for stroke, because how that can play in on your blood pressure, how it can interfere with your sleeping, with your rest cycle, because it's important when you sleep at night as well that your blood pressure drops and that your body gets a chance to refresh itself. So, you know, cocaine use is very high amongst all groups and ages in society. So, and I think a lot of young people don't understand that there's a significant risk of stroke from using cocaine. So I think that's something to put out there. And it is a question that we ask when people come into hospital, regardless of your age, you know. As somebody said to me today, it's nearly easier to get a bag of cocaine than it is to get a bag of coal. You know, it's that common. And, you know, it's funny, but it's true. So obesity and not exercising enough. So I would say to people, you know, a doctor can only help you so much. You have to take responsibility and control for what we do to our bodies to help us to age and do me out of a job.
And you can find out a lot more about risk factors and how to tackle those risk factors, because it can be really difficult to deal with these things that are often part of our day-to-day life. So you can find out more about risk factors by visiting croi.ie. It's absolutely full of resources, and we have lots of services that could be of help to you as well. So, you know, we've said, so we're coming towards the end somehow. I feel like we could talk for hours and hours, but I just want to ask Trish, so you you mentioned that, say, blood pressure and AFib, two major risk factors for stroke that we're talking about at the moment. And in some cases we have symptoms, in some cases we don't have symptoms. Prof. Crowley talked about, having monitors on us. How do people find out if they have high blood pressure or if they have AFib? If someone is worried about any of those things that are listening today, what's kind of the first port of call?
So I suppose the very first thing is listen to your body, understand your body. If you know you're doing something and you know it's not right, so if you are smoking to excess, drinking to excess, you have to take control. You have to try and help yourself as well. But it's very, very important to go to your GP. Go to your GP. I'm going to touch briefly and just say about blood pressure monitors at home, and Declan will start laughing at me when we talk about the blood pressure monitor at home. If you are going to take your blood pressure monitor or your blood pressure at home using your monitor, know how to do it properly. Okay, there is a little bit of a skill that goes with it, and don't let it take over your life. Do not be fixated on those numbers, because if you become fixated on them, that can lead to stress, it can lead to anxiety, it can lead to worry, and that can drive up your blood pressure. So that's one thing. But you're to know how to, have you got atrial fibrillation? The most inexpensive way. These two guys, your fingers. The title of this seminar, this webinar tonight, Finger on Your Pulse. Learn how to take your pulse. And it's a sad reflection on nursing, not just in Ireland, but worldwide. We wheel around the blood pressure machines now. We no longer put the fingers on our patients' pulses, and it's something that we need to start doing. We need to learn. It's a very much a missed opportunity. When you're sitting as a nurse talking to people, for that 30 seconds or for that 1 minute, put your fingers on your pulse. And you can go online, you can learn how to do it, and it's not going too hard, but listen to the rhythm of your body, know what feels right and regular for you. And then, because not every irregular heartbeat, as Jim said earlier on, is always atrial fibrillation. We can have little extra beats that can come and go as well that don't always spell atrial fibrillation. So I don't know if anybody's anything else to add.
Well, yeah, I think it's important. You do need to keep, especially as you get older, you do need to keep in contact with your GP. And we keep coming down to the basic risk factors, cholesterol, blood pressure. And when you're with the GP, it's an opportunity for the GP to check your pulse. And even with the blood pressure monitors, it can be picked up. The atrial fibrillation can sometimes be picked up on the blood pressure monitor. These are really easy things to do, and they make vast differences. As Rónán was saying earlier on, if we could control blood pressure, we could identify it first of all, and then we could control it. If we have a chance to control it now with lots of drugs, if we can identify it. But it's all about identification. So if you do keep in touch with your doctor, it doesn't have to be very frequent, particularly if you're feeling fit in every other way. But it's certainly no harm to get checked out. Probably get a check at least once a year with your doctor, even if you're feeling well, certainly when you're over the age of 50 or 55, because if we can identify it, we can treat it. If we can treat it, we can prevent it. And if we do pick up atrial fibrillation, we can put you into a much lower risk group of patients who would end up getting a stroke. So you'd go from the high risk group to the low risk group potentially by the appropriate drug therapy. So it's easy. It's in many ways easy to detect if you go for it.
Yeah, and well worth engaging. So we are dangerously close now at 8 o'clock. I have one more section to touch on, if that's okay, and totally understand if anyone absolutely can't stay with us. But I was wondering, Ed mentioned earlier being aware of what the treatment for AFib was in the 90s. And I'm wondering, Prof. Crowley, if you could give us a sense of what the treatment is these days.
I thought you were asking that question because it looks like I'm the oldest person here, so I can remember the 90s. I thought it was very unfair.
I remember the 90s too.
I certainly remember the 90s. Yeah, the atrial, the goal. I suppose as I said earlier, I think the biggest change has been our ability to take blood thinner medications, or these new blood thinner medications that are easy to take, do not need to be checked on a regular basis, unlike warfarin, which was a difficult drug to take, even though it was an effective therapy. And I think also the recognition of the very strong association between atrial fibrillation and stroke, and the amount of atrial fibrillation and the amount of stroke that's due to atrial fibrillation. So suddenly we know now that if you have atrial fibrillation, you're at risk of stroke. We also know that in particular groups, you're particularly at risk of stroke. And we also have a good treatment that works very well in reducing the risk of stroke. So all of that together makes a big difference to how we can manage patients, and makes it so important to identify stroke, identify atrial fibrillation. As I said, there's this other group of people, not other group of people, but other group of symptoms that patients experience with atrial fibrillation. And we heard some of that earlier already. So there are many patients who have severe symptoms from atrial fibrillation. And in those patients, we try to control the heart rhythm, the rate of atrial fibrillation, because that can often alleviate symptoms. And in those people in whom we're not able to control the rate, we can do invasive procedures which may eliminate atrial fibrillation altogether, or at least in a significant proportion for a significant period of time. Now, the thing about it is that if you're at risk of getting a stroke with atrial fibrillation and you go ahead and have your ablation, your risk of stroke remains. So if you need to be on a blood thinner before you've had this procedure to eliminate atrial fibrillation, you will still need to be on a blood thinner afterwards. And this is really important, because what it's telling us is that if you're at risk of a stroke, what it's telling us is that all the other symptoms, the palpitations, the weak and dizzies, the feeling weak and so forth, all of those symptoms, they may be helped by the ablation, but the risk of stroke will not be helped. And so if you don't have symptoms, so if we're separating out the symptoms, we've got the risk of stroke on one side and we've got the symptoms on the other side. And so we're giving drug therapies and different treatments to control symptoms, and we're giving the blood thinner to control the risk of stroke. And so if you have no symptoms, you may only need a blood thinner to control the risk of stroke. If you have a lot of symptoms, you may still need the blood thinner to control the risk of stroke. And then you have these other drug therapies and potentially ablation for controlling the symptoms.
Okay, thank you, Prof. Crowley. And I think we lost someone. So Ed, would you mind sharing a little bit of your experience of AFib treatment, please?
So I started down the track. I had a cardio, so I had an angiogram just to check how the pipes were clear, and thankfully that was okay. And I was referred on to a second specialist who told me what ablation was, and it's nuts. I mean, it's just when you actually hear what they do, you just go, no, it's not what I want. But 6 weeks later, I was getting it done. So I woke up in the ICU post-op. I had 2 bruises in my groin area where they go in. It's no scar. I felt great afterwards. I felt sick from the anesthetic. I was also told that I should start exercising the next day and go back to work on Tuesday. So it was Friday when I was getting the procedure. I was back to work, bank holiday weekend. So I was back to work on the first working day, and just kept going and started to do the exercises, lose the weight, walk the hills with the kids, which was great. And fortunately for me, we were talking about the wearables. I used a cardiac wearable. That for me, and I think you could use, as you mentioned, the watches and things that are good too. For me, that was actually what proved that I had this particular problem, that I had atrial fibrillation and atrial flutter, and that I was able to get both treatments for both of the cardiac problems that I had in the one go, and therefore not have to go back in and repeat, which I think does happen to some people. So I think I've been lucky that way. And just to keep it keep it neat. You know, I'm now 6 months post-procedure. I haven't had any arrhythmias that I'm aware of, and I was very aware of them beforehand. Lost 2.5 stone. I'm exercising every day. I've sort of ticked a lot of the boxes of the lifestyle things that Trish was talking about. Stopped alcohol completely, because that's a risk factor I can happily give up on. Didn't smoke. So, and the weight for me was a big deal. I was 19 stone when I went into the procedure, about halfway to my goal weight. So I've got some things to do between now and then, but hopefully I'll get there. And one of my friends said, look, you've been given a second chance. And I think, though I was lucky to get the second chance, because I took a long time to get to the GP, to the hospital. But having taken my time to get there, I got very good treatment. I got some good kit put through me in order to help do the ablation. And I was put on the medications that were required. And now, having given that second chance, I'm sure as heck going to take it. Okay. Thank you very much for your time.
Thank you, Ed. I really appreciate that. So, you know, you weren't jumping for joy about having to go in and get the ablation. It didn't sound good, but
not at all.
You were flying it soon after, by the sounds of it.
Yeah, I mean, the procedure is nuts. I mean, it really is. What they do is you know, God bless their hands is a quote often used, but you know, it's really important that you get the right people doing the right thing. And I remember the anaesthetist saying to me as I was going off to sleep, says, I said something like, oh, lots of Bethadine or something like that, and the laugh is, they know what they're doing. It was very gracious of him to say that as I was going off to sleep.
Yeah, that's definitely the last thing you want to hear in that moment. Hey, good on you. Thank you, Ed. And Declan, can I come back over to you now? You know, we really are coming towards the end now, and I really appreciate your patience now that we're just after 8. Do you mind telling us, Declan, how are you doing these days? You know, how have you been doing in the period since your stroke?
Brilliantly, to be honest. I've been very sober and listened to a lot of this, because like Ed, I feel extremely lucky. What I didn't mention earlier, it was a bleed. I didn't have a blockage. My, I suppose, diagnosis was just hypertension. Undiagnosed high blood pressure. That was probably, I had doubts or suspicions that it was there, and I was doing everything I could to stay off going on to medication. So I was taking beetroot juice, you name it. I was reading about it. I got to love the beetroot juice. Everyone else hates it. You get used to it. So I suppose the message that I'd like to give people is make sure, you know, you check your blood pressure, especially when you hit into your 40s. Be aware of the numbers, like Trish said. Other than that, the hard part for me probably afterwards was side effects from the medication and trying to get that right. That took a fair bit of time to get right. But once the medication started working properly, I felt absolutely normal. The only issues I have now, physically, I'm 100%. It's fatigue is an issue, and less physical fatigue, more, it's very hard to describe actually. It's more like a type of mental fatigue that, to be honest, I wouldn't have believed this type of thing even existed until I had the bleed. So I could, if I'm doing a lot of concentration or a lot of mental work, say my job is busy or whatever, it can really take its toll. I think it was 2 weeks ago, I was watching Match of the Day highlights with my son Sunday morning. I didn't get to watch it Saturday night. So I was just, after getting out of bed, and I'm sitting watching, and all of a sudden I'm gone. Just like a shutdown. And that happened that day around 4 times. I just felt like mental fatigue. And obviously it had been from the week before that, or the days before that. So it's a bit annoying. I'm trying to find more information about it. I've been on the webinars here with Croí. It's something that I know that I just have to deal with, because physically I'm fine. If you ask me to do a lot of physical work, I usually feel okay after that. But a lot of concentration and heavy mental side of things can take its toll. But like Ed, I feel 100% lucky to be here. Lots more that I want to do, lots more of life to live. I put my general health down to the success, because I recovered very, very quickly. The fatigue is, basically the only issue. But other than that, brilliant.
That's great to hear, Declan, and I'm so glad again to have yourself and Ed here this evening. And it's very clear that you both put in a lot of work as part of your recoveries, and are still doing that it's part of your lives now to mind yourselves and to keep recovering and stay strong and in multiple ways, by the sounds of it, as you said, physically and mentally, and so great to hear you're linking in with the Croí supports, and please keep doing that. And to everyone listening here today, there's been a good bit of talk about how important it is to link in with your health services, and if you're already linked in, to keep linking it to figure out your medications, to figure out the symptoms, whatever it is. Everyone's story has really been about a process here.
No, it's so important. Like, the support is so important as well. And people like Trish, like my consultant Neve at the time, they deserve medals. You never forget these people. You never forget the help and the support that you get from them.
I think that's, sorry, Trish.
Just going to say, is my halo shining a bit too bright there, Declan?
It's very bright, Trish.
It'll always be shining as far as I'm concerned.
So I think that's a perfect spot to finish up. So I'm wondering if just before I do a couple of kind of closing bits, can I ask for just kind of one take-home message from each of you to leave our audience with this evening, please? And just to let you know, Prof Collins has had a power cut, and so that's why he got kicked out. So Prof Crowley, would you have a line to finish us up with?
Well, I think it gets back to everything that we talk about always when we come back to all of these things, is prevention is better than cure. And so keeping in touch, getting your just the really basic stuff measured, blood pressure, cholesterol, keeping an eye on diet, and getting your pulse checked while you're there with your GP. Certainly check your own GP pulse, but get it checked. If you get it checked, you know what it is. If you know what it is, we can deal with it.
Brilliant, thank you. And Trish, would you have a parting remark for us?
So I'm going to go know your numbers. Okay, so we'd often have people coming in. I'm sure Jim would have the same. You'd ask people, so what tablets do you want? I'm on a blood pressure tablet and I'm on this. Is your blood pressure tablet actually controlling your blood pressure? So take control of your health, take some ownership, understand your own health, and don't always rely on all the medication. You need your lifestyle factors as well. So I don't want to be seeing you coming in the door. Not that we won't help you, obviously, but try and stay away from us if you can.
Thank you, Trish. Welcome back, Prof Collins. Thank you for making it back on.
Well, actually, they're working on the new children's wing at the hospital, so we get intermittent power cuts late in the evening, but no alarming. We have backup generators. So I think Trish has probably summarised it. Listen, if you suspect you have any symptoms of a stroke, don't idle. Get into hospital, ring 999. And I think Jim and Trish have probably also reiterated, know your blood pressure, particularly when you start hitting your 40s, and know how to take your pulse. I think they're two very simple but important pieces of advice.
Thank you. Ed?
So I was terrified through the process. It's 2 years now since my first symptoms and to 6 months after the operation. Absolutely terrified to the point of not doing anything. And it took 18 months of worsening symptoms and a big kick up the ass from my wife to get me to get treatment. And if I could give any parting message, it's don't leave it too late. Get in there sooner, the sooner the better. These guys and girls, they're clever girls and guys, they're there to help. You know, use the resources that are there.
Thank you, Ed. And
Lisa, can I ask you a question?
Sure.
Because this is an important question, and maybe this is where we need to focus some of our addressing as well, because I know you have a background in health psychology as well. What is it about men when they know there's a worrying symptom that they won't do anything about it? And how do we address that? Because it's a very real thing. I know Ed is described, but it's a very real thing that people come to us so late. And it's particularly prominent amongst men for some reason.
Absolutely. We're so influenced, you know, both men and women. You know, men can really find it hard to go in and ask for help, whatever it is. And sometimes women associate certain symptoms with men, and so if they're not feeling well, they might not start thinking about maybe something wrong with their heart or whatever it is, and can maybe be focusing on everyone else too much. And we hear so much how important partners and family members are to encouraging us to mind ourselves. So I suppose the message here is, whether you're a man or a woman, or you identify as something else, you know, listen to your body, as Trish said, or listen to your friends or your other half, you know, whoever's speaking most loudly, I suppose. So thank you, Prof. Collins. Declan, would you have a parting remark to finish us off?
Well, I thought I'd be the opposite side of the coin on that, through my experience, that I had no symptoms. There was absolutely no warning. There was no hint of it. So if anything, what I would take from everything that's been said is hypertension. People need to be aware of it. I had probably pre-hypertension. As far as I'm aware, it was spiking, especially with stress. But having no symptoms, it's like those adverts years ago that said it's a silent killer, which it is. So, like, I didn't feel the need or necessary that I go to the doctor. They had done a monitor on me maybe when I was around 40, and what it showed was that I had pre-hypertension. Obviously, I hadn't gone back to the doctor that much after that until it happened, you know. So if you have any suspicion, I suppose, of any type of hypertension, get your doctor, get seen to, be willing to take the medication as well, you know.
Absolutely, Declan, thank you. Prevention is better than cure, as they say. Pop into the doctor every year, and keep getting the support that's available, and utilizing it. So thank you so much, everyone. I think that was an absolutely fantastic session, and I really appreciate you bearing with us with the going over time a little bit, but we really had so much to cover. So thank you so much, so sincerely, to the panelists and to everyone joining. We really hope that you benefited from the session to mark World Stroke Awareness Day tomorrow. We had so many questions come through, and thanks to some of the panel members for popping in answers to those questions. It was really, really, really excellent. But if your question wasn't addressed, please phone us during the week, Monday to Friday, 9 to 5. We have our Heartland West phone line, as you can see here in front of you, so 091 544 310, or you can email us on healthteam@croi.ie. You're going to receive a post event survey tomorrow, and you'll receive the link to this session as well if you want to rewatch it or share it with anyone you think might be interested. So please do share your feedback in that survey. If you would like more information on anything that was talked about here, or how you might tackle some of those risk factors that we talked about, get support with anything that you need in relation to your heart health and preventing stroke, please do have a look on our website to find the resources. as you can see here, we're running a stroke-focused series of our HeartLink West chats at the moment. So you can join us each Wednesday at 2 p.m. from now until the 24th of November. And that's on a range of topics to do with stroke. And you can register now at the website that's on the screen, so croi.ie/HeartLink West. And to learn more about atrial fibrillation, you can visit the website launched by our supporters for this evening, Johnson & Johnson, and the website is getsmartaboutafib.ie. So thank you so much again for joining us to the panel, everyone kind of in the back room, the Croí Health team, and to yourselves in particular for joining us. I hope you have a lovely evening and take a moment to think about World Stroke Day when it arrives tomorrow. Thank you again. Good night.